My name is Catie Kelley. I am a policy counsel attorney with Americans United for Life, and today I urge your opposition of House Bill 5219. The bill's purported safeguards cannot adequately protect vulnerable patients. If you look to the language of the bill, it does not require either of the two physicians to clinically evaluate a patient's current mental health status before prescribing lethal drugs. Nor does the bill actually describe or identify a clinical or legal standard for how the physician is to, quote, verify whether a patient has impaired judgment or is capable of making this decision. And a physician only must refer a patient to a mental health professional if neither physician verifies whether the patient has impaired decision-making capabilities. And even then, there's no obligation under the bill for the mental health professional to formally diagnose, evaluate, or treat an individual for depression, anxiety, or suicidal ideation, or any other mental health condition which is well documented to be comorbid with chronic illnesses and end-of-life conditions. Instead, the mental health professional only must confirm the decision-making capability of the patient. But this is not the same as engaging in a clinical review of diagnostic criteria for depression. In fact, recurrent thoughts of death and suicidal ideation is one of the diagnostic criteria under the DSM-5. And so instead, the standard of care when patients ask to end their lives is to evaluate and treat those patients for depression, anxiety, and suicidal ideation. And in Rhode Island, 21.7% of adults have reported a depression diagnosis at some point in their lives. So this means that patients requesting lethal drugs under this bill may be suffering from depression and may not be formally evaluated for it at the time that they're requesting these drugs. This is extremely concerning language in the bill. Physicians should be evaluating and treating these vulnerable patients for depression. We feel nothing but compassion and heartache for these individuals who are suffering. And, you know, if you look to the data in Oregon, the reasons that people choose to end their lives, it's not because of pain management. It's because they're afraid of being a burden, and they're sad to be losing their autonomy. And so there's extreme concern, though, about this having a disproportionate impact on individuals who are suffering from depression associated with these illnesses. Thank you.
Thank you. Any questions? Yes, Leona.
Thank you, Mr. Chairman, and thank you for the testimony. So just to clarify, in terms of your opposition to the bill, so are you saying only those that have depression and anxiety should this bill pass, be able to end their lives? Or is it if you do not have anxiety or depression or any other conditions that you mentioned? If you can clarify that.
Oh, yes. Thank you. Thank you for the opportunity to clarify. So what I mean is that it's well documented that depression and anxiety and other mental health conditions are very comorbid with chronic illnesses and end-of-life diagnoses. And so the bill does not require a physician to actually formally evaluate someone whose mental health condition may be contributing to that decision to end their life with lethal drugs. And so there's extreme concern here that some individuals may be experiencing severe depression and would like to end their lives, but they're not actually going to be evaluated or treated for depression under this bill.
Okay. And in terms of, if I may, Mr. Chairman, for a follow-up. So in terms of right now, generally, right, if I have a medical condition or I want to, let's say, see if I want to see a doctor or someone, I'll go to my primary care doctor who knows me best than any other physician. So why wouldn't that person who knows the record, knows the person's history, be qualified to do so? There is someone who is licensed under the regulations of our state and the board to be able to practice medicine. So why wouldn't that be sufficient?
Well,
if it's sufficient. For example, if I want to go and get a diagnosis like ADHD, which I have in terms and have done, right? Going to my medical provider, I can say, hey, I would like a referral to X, Y, and Z. They review my medical record and say, yes, that makes sense because of your history. So I'm just concerned in terms of the fact of saying that you need to, apart from having your doctor, apart from having your professionals, to now have a third party that you've never met make that decision for you just doesn't make sense, in my opinion.
Well, under the bill, thank you again for the opportunity to respond. And I think that that's a valid concern. My primary care provider knows me best as well. But I get evaluated for depression with the depression screening every time I have my physical annual checkup. But this bill doesn't even require someone who's requesting these lethal drugs to have any evaluation from their primary provider. And so I do check-ins, on mental health with my provider. But like I said, under the language of this bill, your primary care provider doesn't have to ask you about, hey, how are you feeling? Go through any formal evaluation or diagnostic criteria of if a mental health condition might be influencing your decision.
But again, if I may just make a comment, again, your doctor would know you best than anyone. So if you were to have or have experienced some signs of depression or anxiety or such, your doctor would be able to recognize those symptoms. At least, I don't know what other folks' experiences is, but when I go to my regular checkup, my doctor does ask, how are you feeling? Are you feeling blue? Are you feeling down? Is there anything that you need? So they do ask on a regular basis when you go visit your physician, I'm hoping that all of them do. Maybe my doctor is just the best that there is out there and asks every single time. But the physicians do ask how folks are feeling and how they're doing in terms of making sure of doing that assessment. So it's, again, I disagree with you. I respectfully disagree with you in your position in terms of why this is, why this bill should be stopped when we have the regulations and the expertise of medical experts who can assess the patient and determine whether or not they are suffering from some other condition that may prevent them from doing this. But I thank you for your testimony.
Thank you, Representative. If I may just add, there are some studies that unfortunately depression is really not recognized very well by primary care providers. And so, again, for individuals who have those really solid relationships with their primary care providers, I think that is a relationship where your doctor may be able to recognize if something's off. But like I said, there's certain studies that in primary care settings, depression is recognized in less than 50% of patients. And that number is even lower for elderly patients who it's shown in studies that they don't identify necessarily that they're experiencing depression. They may delay care for seeking depression symptoms. So some studies are referenced in my written testimony, but I appreciate your comments and questions.
Mr. Murphy.
Good evening.
Oh, I'm sorry. Edie has a question.
Just a quick question. Are you a medical professional?
No, ma'am.
Okay. It seems to me, from what I've read and from what I've heard from people who have testified and people who have talked with me about this legislation, that a prognosis of 6 months or less to live is very likely to cause a person to feel some depression. It would be, I think, pretty surprising if they did not. So it seems to me that what you're asking for is some sort of measurement of what sort of depression level would make someone unable to make a sound decision for themselves about their own life or death. And that's really more of a comment than a question, especially since you're not a medical professional. Thank you.